The job that I've been given is to conduct this panel discussion, and the experts on the panel are Dr. Shikha Halder from New Delhi, Dr. Sunil Chaudhary from Varanasi, Dr. Patro from Vizag, and Dr. Pooja Nandwani from Ahmedabad. The chairpersons for this panel discussion are Dr. S.K. Srivastava from Mumbai, Dr. Kishore Singh, and Dr. P.V. From New Delhi, and Dr. P.V. Reddy from Hyderabad. So without doing much, I think let's go to the first study. It was a pilot study of FOLFIRINOX followed by chemoradiation for gastric cancer and GE junction cancers. Quite an intense regimen with neoadjuvant 8 cycles and then using concurrent Pacli and Carbo. So Dr. Sunil Chaudhary from Varanasi said, can you just enlighten us on this and present your expert view as to how comfortable you would be doing such a regimen and what are the studies, positives, negatives, and how it is applicable to our Indian scenario?
Thank you. Since it was a pilot study, the sample size, I think it was adequate. Regarding the radiotherapy techniques, they had mentioned only the dose and they forgot about mentioning the technique per se. And I'm not very much convinced with the author's conclusion that it's a very promising protocol, because I could find that 76% of patients had grade 4 hematological toxicities. 20% of patients failed to undergo surgery due to progression of disease. 2 of them. One had expired in the treatment, and 2 of the patients had mets.
Yes, exactly. You see, this is what my question is to the other panelists and to the chairpersons. So, how feasible such a toxic treatment is there in Indian scenario where a lot of patients lack a lot of supportive care, like elementary care during the treatment? Any of the chairpersons or panelists can take.
And I would like to add one more point. Like, despite very aggressive chemotherapy and radiotherapy schedule, 90% of patients had distant failure.
See, distant failure is what is known for gastric carcinomas, and I think by giving such a intense chemotherapy neoadjuvantly, this the whole idea behind the study is to bring down those distant failures. Local controls are very good almost in most of the patients post CTRT. Dr. Sham Srivastava or Dr. Kishore Singh, sir, can you give your opinion on this?
This is a very toxic regimen, there's no doubt about it. It is very effective in pancreas, but doing it in gastric is next to impossible. So we have to find a middle path where we can complete our treatment and with the almost same efficacy.
I agree with Dr. Kishore. I think it's a very, very toxic, and our patients are not in that nutritional status that they can mostly complete. There are very few patients who will complete the treatment. Those who are well built and the nutritionally they are not compromised. So I think it is difficult, and I agree with Dr. Kishore that we have to find some via media in that.
Any other panelist would like to add to what has been discussed on this? So the take-home message is that the neoadjuvant approach seems feasible, but as the experts and the chairpersons find that it is a toxic regimen, its applicability to the Indian scenario is quite questionable because a lot of our patients do lack the nutritional support during treatment of CA esophagus and upper GE junctions. So I have my apprehensions, and I would leave this study here and go on to the next one, which is patterns of recurrence in critics gastric cancer trial. Again, we know that gastric cancers have a lot of recurrences. Most of the patients are recurring within 2 years of treatment. So it's a Dutch group study. Dr. Shikha Halder from Delhi, ma'am, we would like to hear your opinion regarding the strength of this study, any weaknesses to find out, and it's applicable, how true are this in our Indian scenario also?
There are a few points, like let me start with the positive ones. Like it is a trial combination of McDonald and Magic trial. And here we are trying to do away with one modality. We are comparing treatment with two modalities, that is chemotherapy surgery versus chemotherapy surgery and radiation. So as we know, as a radiation oncologist, we have all faced treating stomach bed in an operated patient is sometimes little technically difficult, because you have an operated bed and the anatomy completely changes, and a lot of normal tissue comes into the field. So if we can find a same result without radiation, maybe that we should accept that. So in this study, but the negative the results in both the testing is equivocal. So if you think like centers which doesn't have radiation, maybe they can use this trial. You can use this regime. But the negative point is that the toxicity in both the arms were very, very high. The completion, the protocol was completed in both arms. Only 50% of the patient could complete the treatment. So either the patients were not suitable, or the regimes were too toxic, because pre and post chemo along with radiation. Maybe it was the patients are, especially our patient will not be able to tolerate. I think we should, our future direction should be more on pre-op strategies like rectal cancers than pre and post-op strategies.
Ma'am, in your institute, are you following for gastric cancers the pre-operative?
No, we are following McDonald's. We are following McDonald's.
And I'd like to listen from the other panelists also. What is the strategy for gastric cancers? Any neoadjuvant therapy being added after the McDonald's? Well, I think in most of the institutes, it is neoadjuvant chemotherapy followed by surgery that is being followed, and radiation for very selective post-op cases. Ma'am, what is your opinion regarding the per protocol patient results that they're showing?
Yeah, the per protocol, if they're able to tolerate the protocol, this seems to be, it is favoring the chemotherapy arm, because at least one factor is reduced, the peritoneal metastasis is reduced, and DFS and OS both are better, but as long as they're able to tolerate the treatment. So I don't know, in our hospital we are quite often irradiating the patient. I don't know about the other centers.
Dr. Kishore sir, how are you treating these patients, gastric cancer patients?
Generally, we are getting only post-operative patient.
So, sir,
no, radiation is never, we are not usually giving it pre-op unless it's a palliative intention. So usually that is the one I was saying, it's technically a little difficult, because the stomach is gone, and the large intestine, small intestine home into the tumor bed. So a lot of normal tissue gets treated. I don't know about others,
Thank you, madam. So I think the take-home message is that it's difficult to treat with radiation post-operatively. We should think of treating with only one modality. And if chemotherapy can give us less peritoneal metastasis and a better OS and an EFS survival, as it is being shown in per protocol analysis here in the study, maybe that is the way forward.
That's correct. I'd like to make a comment there. We should not be so hasty in not giving radiation, because if you see both the result, chemotherapy group had more toxicity. If you see from the toxicity point of view, chemotherapy group had little more, not statistically significant, but had more toxicity. I think we should think about some other strategy to
one very important thing that I feel in our Indian scenario is how good is the D2 dissection that we're getting.
That's true. That's true.
So that is where I think the role of radiotherapy cannot be negated. But if it's a good D2 dissection with a node negative patient, I think maybe chemotherapy alone may be the way forward.
Yeah, definitely we need more trials, confirmed, because
our own trials where we are having.
the stomach is a bad cancer. It's a bad
Yes,
cancer.
yes. Totally agreed, ma'am. Thank you. I think let's go on. And you see, this is what, like you were saying, ma'am, the pre-operative chemotherapy should be like maybe intensified, or maybe the radiation should come after a pre-operative chemotherapy. These are few strategies that can be evolved to overcome the problem of gastric cancer, or just the radiation like in the prostate we are doing. Maybe we should all sit down and collaborating with each other, institutional studies going on to give some results. Thank you, madam. Thank you, sir. And next, the abstract was, it was a like a molecular analysis of the genomic landscape of the anal cancers and its relationship to the clinical outcomes. It was on the exploratory analysis of the NRG oncology RTOG 9811. So it's an abstract towards precision radiation. So it has explored mutations like EP400 and other epoch mutations. So Dr. Kanu from Vizag, sir,
Yes,
can we have
yes,
some
sir.
expert comment from you regarding the strengths of the study, any weaknesses you could find out, the relevance of doing such a extensive genomic testing? And another question that has come up from in the chat box has been regarding the cost of doing all these tests. Is it actually going to help us change our clinical practice? So, Dr. Patro, your opinion on this, sir?
So this is mostly a genetic study, and to evaluate the which is the most worst outcome and is a good outcome, and they found out that PI3K pathway is the most common, and the FBXW7 is the worst outcome. So these are the preliminary, mostly minimum number studies. They hopefully it will come in future to individualize the treatment, and those are with worse prognosis. We need some aggressive treatments or some maintenance treatments after the chemoradiation. So let's wait for the long report and many studies to come out. But when these are the not possible in an Indian scenario, or it in our perspective, but future is there.
I think they have still not done the analysis of the cisplatinum arm. Only the MMC arm has been studied extensively.
Yes, sir. Yes, sir.
I think it is just an initial paper that coming out of this group. Maybe the subsequent papers will definitely guide us further. But one thing is for sure, that we are now in an era of precision radiation oncology, and apart from improvement in technology like the IMRTs and the AGRTs, VMATs, I think we should also be very seriously looking at the genetic part of the tumors and its incorporation and its association with radiation oncology to take the branch to the next level in the coming years. Dr. Srivastava sir, we would like to have your opinion on the era of precision radiation oncology. Or Dr. Kishore Singh or Dr. Reddy, anyone?
These are baby steps towards precision oncology. Lot of work is still to be done. We are also installing one NGS. This machine has already been come, and we'll see a lot about this thing in future.
Sure, sir. So next, I would like to take up the study of patient-derived organoids as a prediction of chemoradiation responses in locally advanced rectal cancers. Another interesting study. So, is it time for us to broaden our horizons by including these tests of molecular and genetics as a routine in our clinical practice? Dr. Kanu, again, Dr. Patro from Vizag, I would like to have your
Again, it is one of the another genetic studies, and so they've given radiation of 8 gray and they evaluated the organoid again. So again, so if the some responses will be there, some patients are not responded well, some patients are not responded well. So accordingly, if these are all mostly again baby steps. So those are not responding well, we can start in between aggressive treatments, or we can continue some mode of changing the treatment policy in when they are not responding, but still needs more data and more results in future. But these are the I call as baby steps, but it is a good steps to evaluate the who are responding and not responding.
Yeah, it's. I think it's very important because a lot of time in the clinics, the patients would come and ask you regarding the prognosis and outcomes before undergoing chemoradiation. I think it is a good tool coming up which can help the radiation oncologists actually to answer all these questions apart from only the clinical experience of the consultant.
But the organoids they have taken after 8 gray, it is not feasible to go for frequent biopsies and all things also.
Yes, so this was another question that had come up, that should this kind of testing be done, and if at all at such a frequency. See, it is and how applicable that is to our Indian scenario. Maybe we'll have to do our own studies of less testing and more results out of these baby steps. Dr. Kishore, you're doing take-home message on this, sir.
Precision oncology is going to come because technology is evolving and it is becoming more and more within the reach. And we will see in future select the patient according to genomic landscape. Beyond the TNM and other things. It is the genomic landscape which will be the deciding factor in future.
So let's take up the next paper. The next paper that I think we take up for discussion is the stratification for risk of early metastasis by a baseline CTC, again molecular genetic and testing for locally advanced rectal cancer, in neoadjuvant setting. So Dr. Chaudhary, can we have your opinion regarding this study again?
Sure. I fail to understand why the authors carried, because there were 552 enrolled patients, and out of 552, only 83 patients had undergone CTC count analysis. So I fail to understand why this was done.
Yeah, this is also something that's intriguing in this study, that out of so many patients, why such a small number of patients did undergo the CTC counts.
Yes.
But sir, what about the results? What do you think about doing this kind of a stratification? Because it again can be a very good prognostic tool for our patients.
But we know that CTC analysis is not fail-safe. Like out of the several CTC shared by the primary tumors, only about 0.1% survives in the circulation, and only about 0.1% is responsible for mets. So should we count on CTC analysis so much so as to predict the distant mets?
I think it is just an addition to the armament of investigations that can be done, rather than just solely relying on it. Naturally, the clinical parameters like the stage, the nodal involvement preoperatively, the involvement of the CRM and other things would stand out and contribute towards the stratification in any case, as they are doing right now. So Dr. Kishore, sorry, sir.
Can I add one more point? Like we all know that CTC is not continuously shed in the circulation. So having blood sample at one point of time may give wrong results.
Yeah, that is very true. That is why they have taken up analysis again and again in this study. And we also know that all patients may not have the CTC who have the tumor, so that also is a shortcoming of this technology. So the take home is that this tool may strengthen the pre-treatment risk assessment for the patients with LARC, and that we do need further research. Of course, and at the same time, the different methods by which they are doing CTC, the research is going on in that field also with the molecular scientists. And in this, they had shown that the herpes simplex virus-based technology was a good tool to use count for the CTC. So next, I think is again an interesting paper which is coming out from Korea, and this is something that we do more often, and we find more often in our clinics, where we have patients of hepatocellular carcinoma not fit for transplants and who had days and failures. And is that the end of it? Dr. Shikha, ma'am, we would like to have your comments on that. And I know that you are doing a lot of stereotaxy at your center also. So if you can share your personal experience on these kind of patients.
Definitely, it's a very, very promising trial. And we do get HCC, and we are treating in our department. Till date, we have treated about 16 patients, but the dose which they have used, we have not been, we were not brave enough to use such doses. Basically, what the results is fantastic. 90%, 2 years control, 5 years control is 80%. Local, I'm talking about local control. But one should remember to deliver this kind of trial treatment. We need a very, very good setup, very high-tech machines, and one must understand they have not mentioned how they have treated, whether they have used intrafraction imaging, the tracking of the tumor, because you see, putting a fiducial in these patients sometimes is very difficult, because most of them have altered coagulation parameters. And if you are going to take ITV, then the volume becomes small. So that
dose is very difficult.
Yeah. So stomach and intestine, usually, except for when it is that the tumor is in the left lobe, very close to stomach, then it becomes. Otherwise, most of the time, stomach and intestine are not close to the tumor. 90% of the time. So toxicity also, we also have not seen any toxicity. I must say that our follow-up is not so good, because the patients again go back to their because they are medically unfit for surgery, or have a lot of comorbidity, or not fit for transplant, then only they are referred to us. So they are usually back to gastroenterologist or the transplant team. But one more I can say is we have also treated portal vein thrombosis, which SBRT is very effective in treating portal vein tumor thrombosis, and we enable them to undergo surgery. So that is another indication. So, but I feel with this study, at least I will be very encouraged to use higher doses where the critical structures are not close by, or it's a very, very small tumor. And I think we should, and though the sample size is more, I think we should, we should be expecting more number of patients with this kind of treatment, and maybe we'll challenge the surgeons.
Ma'am, thank you for sharing your own experience. How much RALD a problem in these patients, ma'am? You've been treating them regularly. The radiation-induced liver damage, which is...
You see, that is what I was telling Jaskaran. Patients don't come back to us, only when they come back if they have a progression, to assess them, they go back to the being a primary physician, because they have other comorbid conditions. They have, either hepatitis, and they are undergoing treatment for that. So either they go back to the transplant team or go back to their own gastroenterologist.
But I think, ma'am, that it is very important that radiation oncologists do take stereotactic radiotherapy for liver HCC in a compost setting, like you said, because this can actually change the outcomes for quite a lot of patients.
Your voice is not clear, Jaskaran.
Yeah, I was saying that it's very important that radiation oncologists take this thing
Yes, definitely.
initiative to treat these patients, because
Yes.
otherwise most of these patients are actually doomed, and radiation, a good dose of radiation can actually change the outcomes in a few of these patients.
We should have a team effort with the radiologist or the RFA or the TAS or TARE. We should have a team and we should discuss together. And the fact that we have treated about 17 patients, that means at least our hospital are gaining confidence in us, referring those patients. Obviously, some of them must have been doing well to refer the second or third patient to us. That is what my feeling is.
Surely, ma'am. Like in Rajiv Gandhi, we also have a good teamwork between the interventional radiologists, the radiation oncologists, and the GI surgery team and the transplant team for these patients. And slowly, we also see that the number of referrals are increasing in our center.
Yes, slowly, I think
this would be a modality.
They are warming up to the idea of SBRT in HCC.
Yes. So, thank you, ma'am. Thank you very much for your opinion. And I think I'm again getting a message to wrap up this discussion here. And thank you to my persons being here and the panel discussion. And back to the chairperson. Thank you so much.
Thank you.
Thank you, Jaskaran, and thank you all the chairperson. It was a nice meeting.